Hi, welcome everyone. I'm Sally Bradshaw, and I'm delighted to welcome you to Navigating the Unexpected, a journey through comprehensive breast cancer care. And this is a virtual discussion hosted by Tallahassee Memorial Healthcare, our hospital for life. So we're delighted to have you here with such an incredible panel of experts and providers located right here in our community. I'll be moderating our discussion tonight. I'm a substitute for Alicia Hill, so be patient with me, last minute substitute. She unfortunately had a situation with family members as a result of Hurricane Milton, and so we're thinking of her and wishing her the best. I am currently serving as the board chair of Tallahassee Memorial Hospital, but more importantly, I am a breast cancer survivor. I was diagnosed 4 years ago in the middle of COVID at a very scary time, and was fortunate to have some of my treatment at TMH, and I'm just grateful to have these amazing people captive. For those of us who are interested in breast cancer, whether we are survivors or we're facing it right now, or we have family members, most women will never face a breast cancer diagnosis, but I think all of us know someone who has been impacted by this disease, family members, friends. Some people have high risk factors, but suffice it to say, regardless of your risk, a breast cancer diagnosis is an absolute shock. It is unnerving, it is unexpected. So, where do we turn when we receive a diagnosis? And I'm really pleased to say that the Walker Breast Center at TMH provides this region's most advanced care, comprehensive care right here in our own backyard. So, thank you to all our panelists for being part of this effort in reducing the time it takes for a patient to go from diagnosis to treatment and cure. We're really glad you're here. We are, as I said, joined by an incredible panel tonight of TMH physicians. I've told them already, I'm glad to have them captive for an hour. They're all breast cancer experts that bring a really unique perspective to breast cancer care. Those panelists include Dr. Shelby Blank, who is the medical director of the Walker Breast Program and a general surgeon at TMH. Dr. Blank, welcome.
Thank
Dr.
you.
Shlermeen Everidge, a fellowship trained breast surgical oncologist at TMH, who was here, left to go do some fellowship work at MD Anderson, and we're thrilled to have talked her into coming back to Tallahassee. Dr. Janine Silberman, a medical oncologist and also a psychiatrist at TMH. So, we're going to be able to talk a little bit about the mental health impact of a breast cancer diagnosis. Dr. Alfredo Paredes, a plastic surgeon at Tallahassee Plastic Surgery Clinic and TMH. Dr. Paredes, always great to see you. Dr. Scylla Popple, a radiation oncologist at TMH, welcome, and Dr. Maribel Lockwood, the medical director of Radiology Associates of Tallahassee and a breast radiologist at TMH. So thank you all for joining us this evening. Some viewers submitted questions in advance, and I'll share those with each of the panelists. If you have additional questions, do not hesitate to ask them. You can go to the Q&A tab on your screen and just enter those. And Greg is here from TMH's Foundation, and he and I will help monitor those and we'll work them in to the presentation. But I want to start first for everyone with where breast cancer journeys start, which means we're going to start with screening and diagnosis. I think for some, diagnosis is the most challenging part of the journey because you're really unsure, what does that mean and how can I quickly come up with a plan? And that's where the Walker Breast Center, I think, makes a significant difference for patients in the Big Bend. So I want to start with Dr. Blank, the director of the breast program. Can you talk, Shelby, about the importance of screening and particularly detecting breast cancer early? Why is that so important to get your mammogram, and why does it make a difference?
Absolutely. I mean, we certainly know that early diagnosis allows us to find these cancers at a small size, sometimes at a pre-invasive stage. But certainly, the earlier the diagnosis is made, the better the prognosis. And so, we know that screening imaging, screening mammogram is kind of our best option to find those at a point where they're not palpable. There would be no other way to determine that there was an abnormality there. So a lot of folks kind of feel like, well, gosh, no one in my family's had breast cancer, so I'm at low risk, so I don't really need to get get surveillance or get screening. But what we do know is that mammogram is not perfect, but it is certainly the best option we have, and is very, very good at detecting these cancers before they ever would become noticeable, palpable on physical exams.
At that point, who should get mammograms and how often? At what age typically is it recommended that you start getting mammograms? If you do have a history of breast cancer, should you get those mammograms earlier? What do you recommend?
So I'll kind of start, and Dr. Lockwood may want to chime in as well. For average risk women, we still recommend screening starting at age 40 with an annual mammogram. If there are other extenuating factors, strong family history, different personal history, those are conversations certainly to have with your primary doctor, because there are people that we will start screening earlier. All women should have at least a discussion at age 25 about their family history and any other risk factors, so that for those people, if we do need to start screening at an earlier age, we can do that. And those people are typically going to be folks who have a close relative that was diagnosed at a very early age. So those are people whose mom had breast cancer at 32. Moms had breast cancer, because those people, we really want to start that screening 10 years before the diagnosis of their close relative. So those are some of the outliers. But for average risk women, annual mammogram starting at age 40. When we stop screening is also can be a gray area. And that has a lot of factors, and again, that's a conversation with your usually with your primary doctor, but a lot of it is impacted by what your state of health is. So there are people certainly living to productive, active lives, well into their 80s and 90s, and so those are folks we don't want to miss an opportunity. At the same time, we want to be mindful that we're not putting people through things that they don't necessarily benefit from. So Dr. Lockwood, I'll let you chime in as well.
Hi, thank you, Shelby. Yes, for patients that participate in screening, those are the ones that are going to get the greatest benefit when we're looking for early breast cancer. And like Dr. Blind said, those are the ones that we're going to find them early, that where the treatment is going to be most effective and less harmful. So those are the ones that you don't feel, you cannot see, the doctor cannot feel. So like screening means for an asymptomatic patient.
What does a symptomatic patient look like? You mentioned people who can't see or feel a spot. That's where mammograms come in and screening. But are there symptoms that women and also men should look out for that potentially would be breast cancer related?
No, screening means a totally healthy person that doesn't have anything. So that's why you screen for a disease that is very frequent, and that's breast cancer. Breast cancer is the second leading cancer that causes death in women. So, but you don't, it's like lung cancer is the first one, so you don't feel it. And
Right.
that's when you establish a screening program to catch it when it's early enough, or as early as we can. So when you have problems, pain, palpable a lump, that is called a diagnostic. And that is, now you are looking specifically at one area that the patient has symptoms for.
Got it.
So as Dr. Lockwood pointed out, there are certainly a palpable mass is the most common thing that we think of as a presentation of a new breast cancer, but skin changes. So an area that looks like a rash but doesn't act like a rash. It doesn't itch. It doesn't go away. Nipple discharge. Pain is a very nebulous, so I never tell people never. It's not something that we commonly think of as the very first presentation of a breast cancer, but I would say any change. And we used to really talk about breast self-exam and the importance of that, and we really replaced that with what we call breast awareness, which basically means be aware enough of what's going on with your breast in general, that when something new or different crops up, that you don't miss it, that you're aware of it and aware that it's something different. So certainly that can be, again, a mass, a skin change, nipple discharge, particularly if there's any blood in it. Those are typically the things that we think.
And that would apply to men as well as women, men who are at
Correct.
risk of breast cancer, the same type of
Correct.
things.
Um,
Oh, go ahead, Dr. Blank, go ahead.
I was going to say certainly men are not exempt. We think of this as a female disease, but we certainly see men with breast cancer, and almost inevitably they will present as a palpable mass because it's much easier to feel a mass in a male breast cancer than in a female.
Thank you. Dr. Lockwood, how does a radiologist fit into the process of diagnosing breast cancer? And when you see a breast cancer, how do you communicate with this team so that you can quickly have follow-up for the patients?
Yes. So what happened is that a screening mammogram is a radiological exam. So that's where everything starts. Patient is asymptomatic. They participate in a screening program, so they come hopefully every year to have their mammogram. So the one who reads that is a breast radiologist, and that's where it comes. So we see the exam. Most of the time, it's going to be negative. It's going to be normal or with benign findings. But sometimes we find things in the mammogram that we call back the patient. So that when you call back the patient, it becomes a diagnostic mammogram. So once that is what we call a category 0 because it needs a further assessment. So then we call the patient to come back, and then she gets a diagnostic mammogram that is read on the spot. And the patient leaves that day knowing if she needs a further investigation like a biopsy. So then once that happens, if the patient, again, most of the time you come back for a diagnostic mammogram because we found something in the screening. It could be cancer, but the majority of times it's not going to be cancer. So we're going to tell the patient, this is benign, nothing to do, come back for your regular mammogram next year. But sometimes there is something that we cannot differentiate between cancer and non-cancer, and that's going to need a needle biopsy. Or something that is very suspicious and it will need a needle biopsy for confirmation. So then we schedule the patient for that biopsy to be done by us. So once that happens, the patient returns for the biopsy. It cannot be done the same day because, there is really, for to do a biopsy the same day, you have to have something like an abscess, something that is an emergency kind of thing. This is not. This can wait. Not 3 months, but it can wait 2 weeks. So that's what we do. We schedule the patient within 1 to 2 weeks. The patient returns. We explain how the biopsy is done, obviously, before the biopsy. We do the biopsy with a needle, and then the results come back. When the results come back, then we call the doctor that referred the patient with the results and call the patient. If it's benign, we tell them that nothing to worry about, to continue with your regular mammogram next year. If it's cancer, then we contact the doctor, let them know that the results are cancer. And what we recommend to do on most cancers, not all, but most of them, is to have an MRI of the breast. So that's the kind of this next step. But at the same time, we contact, either we do it or the referring physician does it, refer the patient for a surgical consultation. So that's when it starts where, okay, now we have a biopsy, a diagnosed cancer, then eventually it's going to need a surgery. So right there, we get the referral to the surgeon and also an appointment for an MRI of the breast. And what the MRI of the breast is going to do is going to tell us more about what is the extent of the disease. So how much of that cancer is occupying the breast? We saw it already grossly on the mammogram and on the ultrasound if the patient had an ultrasound, because that was a cancer that could be seen by ultrasound. Not all of them can be seen by ultrasound. And so the MRI is going to show that exquisitely with the extent, if there is more cancer in that breast or in the other breast. So by the time the patient has the appointment with the surgeon, hopefully, and most of the time that's how it happens, they go with all that information, including the MRI. So it's better for the surgeon to plan the surgery. having all that information.
And you would do an MRI of both breasts, not because you assume there's a cancer in the other breast, but to eliminate the possibility that that is the case.
That is correct. And also, when we have pair organs, it's good to compare one to the other. So that helps a lot when it's normal features of one breast, the other one has a tooth, it's less likely to be something abnormal.
A little bit, Dr. Lockwood, about the staging process for a breast cancer tumor, what that looks like, and why is that important to identify the stage?
Well, we do what we call focal staging. The real staging, the final staging is after surgery, because then you get the final piece for the pathologist to examine, and also you're going to, depending on the cancer, you might get a sentinel lymph node, which is an excision of your first lymph node in your axilla or underarm, so for everybody to understand. And so that's the final. The MRI, what it gives you is a preliminary or a focal staging, because we cannot see the whole axilla, we see part of it.
Right.
So we don't really give the term staging in our reports. We leave that for the surgeon and the oncologist.
That happens after you've actually. Oh, go ahead, Dr. Blank.
Sorry, no, I can add a little bit more to that.
Yes, absolutely.
For when they see the surgeon and we do our physical exam, we review all the imaging and everything. That's when we can pretty fairly give a clinical stage. So we do clinical staging before surgery happens, and that includes the size as we know it to be true based off of imaging, based on physical exam, how their lymph nodes feel on our exam versus also how they look on imaging. If everything kind of looks normal, we can give a clinical stage for that. And then after surgery, when we have a true size, true lymph node status, that's when we have what's called pathological staging. And that's the, both are stage, 0 to 4, but they just different nuances and how we obtain that information, clinical versus pathologic staging.
And what does staging tell you, Dr. Everidge? Why do you stage a breast tumor?
Yeah, so staging pretty much equates to prognosis and how well patients do. We know that earlier stage breast cancers do much better, and the overall survival for most early stage breast cancers are in the 90%. And then the higher stage, the worse the prognosis is. So that's kind of how we all use the same nomenclature to be on the same page about someone's breast cancer.
Another reason to get your mammogram, because you can catch it earlier and likely treat it better. I want to talk about breast cancer care and treatment, because at the point you receive the diagnosis, at least for me, I'm a planner and I immediately wanted the plan. I mean, the minute I had a few minutes where it was a tough diagnosis. And then I said, what are we going to do? How are we going to treat this? And that's where the Walker Breast Program, I think, is so important in this panel of experts. Dr. Blank, can you talk about what the experience looks like when you come to the breast program and how each of you work together for the individual patient who receives a diagnosis?
Absolutely. So I think you've just kind of identified that kind of moment of chaos when you receive your diagnosis. And for everyone, it takes a little bit of a different length of time to kind of process that. But the idea is that you are again, you're anxious to get on to the next stages and to plan what comes next. So what we realized is that we had all of the pieces, but they kind of all operated in a little bit of an individual way. And so our goal with this program was to bring all of those pieces together. And to take what was maybe a process that took a little bit longer, a process that left a little more to the patient in terms of getting referrals and seeing people and going to different offices, and to try to bring those as much as possible kind of under one roof, under one day, and really expedite that process. And so for every breast cancer patient, their treatment will look very differently, and their recommendations may be very different. And so our goal was to get them all of the information that would allow them to make those decisions, see the people that really they needed to see to make those decisions, and give them immediate recommendations that brought in all the different disciplines. So, that Dr. Silberman from a medical oncology standpoint, Dr. Popple from a radiation oncology standpoint, would be able to lend their expertise, that we would re-review the imaging with Dr. Lockwood, that we would review the pathology with our pathologists, and that we could set up kind of an expedited referral to Dr. Paredes and our plastic surgeon. So that's the whole idea, is that we look, staging is very important, but in today's world, even more important is the tumor biology. So what kind of breast cancer do you have? Does it have certain markers? Is it hormone sensitive or not? Is it triple negative or HER2 positive? All of those things that have made breast care a little more complicated, but those also impact the order of treatment. Some people will benefit from having chemotherapy immediately. And so those people, it's a great benefit that Dr. Silverman is right there and can see them that day, make those recommendations and start that treatment. Other people may not need that right away, but they may be trying to decide between mastectomy and lumpectomy, and they want to understand what radiation is all about. And so the ability to meet with Dr. Popple on that day. We have our genetic counselor. So for patients who have strong family history or maybe a diagnosis at a very early age, we can get their genetic testing initiated, because that may impact their recommendations or the surgical option that they choose. So the idea was to bring this all under one roof. So what it looks like in practical terms is the patient comes in, meets with our has already met with our navigator, meets with our navigator. We can identify any barriers to care or any impediments, whether it's, travel or job stresses or finances or what have you. She meets with, the patient usually meets with one of us, either Dr. Everidge, Dr. Howard, or I, and we kind of talk about their diagnosis. And then we meet with our interdisciplinary tumor board right there while the patient's in-house. And we go over everything. We look at their imaging, we look at their pathology, make recommendations. We meet again, kind of tell the patient our recommendations, if there's any additional imaging, additional biopsies that are necessary. And then they have the opportunity to meet with the other members of the team as needed. So medical oncology, radiation oncology, genetics, et cetera. And so ideally they leave there with, in writing and in their mind, a plan of this is what's going to happen. This is the time frame, and hopefully some order from the chaos. So that's a little bit what it looks like.
That is a huge thing for any, I'm sure, patient of a chronic illness of any kind, but it is certainly something that the Walker Breast Center offers, one-stop shopping, I'll call it, where you can get your answers quickly from people who are totally focused on you and your care. Dr. Everidge, speaking of sort of care that is top-notch, can you talk a little bit about your fellowship at MD Anderson? You came back here to Tallahassee as the region's first fellowship-trained breast surgical oncologist. What does the level of training you receive mean for patients in our community? What were you able to bring back from your experience at MD Anderson?
So I want to start off by saying, having the ability to have done my residency training here in Tallahassee and then go off to MD Anderson, I was able to go there and really kind of put together that we're doing the right stuff here. So, the surgeries, we're offering the right care. Fellowship training, I was able to fine tune things, kind of go into the why we do certain things, look into the literature a little more critical, kind of approach things from a more scientific perspective. I got to train with some of the leaders in the breast cancer field. And, I'm able to, I keep in contact with them. So, really what it's trained me to do is keep up to date with what's going on in the breast world. And I'm able to bring that kind of level of science back to what we're doing here. But I mean, it really helped me feel comfortable with coming back to Tallahassee, really comfortable with coming back to Tallahassee, because I realized we were already giving the best care we really could here.
We're so glad you came back.
Thank you.
Thank you for not forgetting about us. Someone just asked in the Q&A a question about insurance, and I know you guys are experts in insurance more than you want to be, but Dr. Blank, as part of the process of the navigation process, do we have a team helping patients identify insurance and what pays for what and how to go about dealing with the complications that brings?
Absolutely. We never want anyone to feel like they can't get care or that they have any different level of care because of what insurance they may or may not have and what coverage they have. And so one of our, big goals with our navigator and our navigational services is to identify people who may have, a less coverage, no coverage, gaps in coverage, so that we can help get them plugged in with what they need. TMH has been super great in helping support us. The TMH Foundation is really great at helping with that. So patients who may have insurance that doesn't cover a PET scan or an MRI or some other piece of their care, we've been very fortunate that the TMH Foundation is able to help us out with that. While also we try to get patients plugged in, because obviously this is not just a now problem. It's
Right.
we want to make sure that patients have coverage for surveillance and for anything that may come down the road. So getting them plugged into the most appropriate level of coverage. So we don't want that to ever be an impediment or a concern. There's enough concerns going through this process without that being one of them. But so, people sometimes ask, well, when I make a donation or, when we do fundraisers or whatever, what does that really do? And that's really what it does. It impacts patients. It provides technology for us that benefits all patients, but it also can provide care or assistance for people who need specific things that maybe their insurance doesn't cover.
And it allows that care to follow them because the journey is not over. Even when you're cured of breast cancer, you're coming back regularly for MRIs or mammograms or to be monitored. I want to switch to Dr. Silberman to ask you a very specific question. What kind of drug treatments does TMH provide for patients with breast cancer? And beyond chemo and immunotherapy, are there other treatments or trials that we're engaged and involved with?
Thank you. So what determines what sort of medical therapy a breast cancer patient gets is determined by their stage, which we just spoke about a little bit, and also the biology of the cancer. So does it express hormone receptors? Does it have the HER2 receptor? So we look at the two things in conjunction, both the stage and the biology, and that helps us prognosticate, but also to figure out what the best treatment plan is for the patient. So it may involve no medical therapy at all for some patients with very early stage cancers. For more aggressive cancers, it might involve a HER2 targeted agent. For triple negative breast cancers, which are very aggressive, we might incorporate conventional chemotherapy with immunotherapy. And then for the hormone receptor positive breast cancers, if they're large enough, then we might want to give them endocrine therapy, which is an anti-estrogen treatment, typically a pill, although we do also have an injection form. So there's a variety of different treatments. In addition to the standard of care treatments, we also have clinical trials. I think the latest count is that we have 5 breast cancer trials, which are enrolling right now. We have another one that's going to open soon, and then we also have a registry trial. So we have a very robust clinical trial program that's headed by my good friend and colleague, Dr. Karen Russell.
That's great. And how involved is this group with clinical trials, at least in following them, processing information, learning about, what's working?
Very. So, our staff attends all these breast conferences. So we are always looking to identify patients who are eligible for the trials and capture them as early as possible. We have a dedicated research staff, highly trained nurses and folks with PhDs in various science disciplines. And then Dr. Russell, who's sort of at the helm of that program.
So another advantage to everybody being right here, where you can meet around the water cooler and constantly, swap updates and
Yes,
share
absolutely.
information. It makes a huge difference. Thank you, Dr. Silberman. Dr. Popple, question about radiation therapy for you. We know that it's used to kill cancer cells and shrink tumors. Can you talk about what the course of radiation therapy looks for patients? I know sometimes it's different for different patients depending on their diagnosis. And also, I think that we have at TMH upgraded some of our radiation technology over the past few years, if you can address that as well.
Sure, sure. All that's true. In terms of the course of radiation, you're right. It's different by patient, and largely it's impacted by the patient's stage, but also other clinical and pathologic factors come into play. Typically, we treat patients over the course of anywhere from a week to 6 or 6.5 weeks, depending on their exact case. And we have been able to update our technology recently. Radiation is delivered using a machine called a linear accelerator, and we've recently updated 2 of our linear accelerators, 2 of our 3, to some of the newest technology actually available. These machines are capable of even more precise treatment delivery than was previously available. The imaging and setup certainty is superior to previous technologies, and we're also able to deliver faster treatment, so it's more comfortable for patients as well.
Pretty remarkable how much work and effort the team puts into exactly where to radiate the breast, how to radiate the breast. I feel like you guys are engineers as well as physicians. It's amazing the work that goes into that. Dr. Lockwood, I know that additional imaging is needed as well, both to determine how to radiate, where to radiate, but throughout treatment. Can you talk a little bit about what is typical for a patient on additional imaging through their treatment?
I'm sorry, my dogs want to be in the
No,
in the
we
webinar
welcome
too.
your dogs.
They have been very quiet, and in the moment you said Dr. Lago, they start talking.
No problem.
See, sorry. Well, additional imaging, usually radiation oncology is different than radiology. So for us, for the diagnostic part, additional imaging is only going to be needed. For instance, after you get the biopsy, we put clips to make sure that the clips are in the right position, because sometimes they can, I don't like to say migrate, but that's the word that comes to mind now. So when you are deploying the clip, you deploy it with a shaft, kind of a guide. And then when you take the guide off, for many reasons, the clip can get a little bit engaged with that guide and comes out a little bit and then falls into the breast. So that's when we said that the clip migrates. And that happens a few times, but it does happen. So we need to make sure that post-biopsy, we are making sure that the surgeon knows that the clip is not where the cancer is. So that's one of the imaging that is post-biopsy. The other one is when the patient doesn't go to surgery immediately, but they need chemotherapy first, that is called neoadjuvant therapy. And in order to know if the neoadjuvant therapy is working, then they get a radiological study. So most patients have had an MRI, so the best study to confirm that it is working or not will be another MRI. And then in the MRI, we said treatment, there is a complete resolution of the findings. Still, the patient will have to have surgery because there are microscopic areas that we won't see, but it's a good indication that the treatment is working. But sometimes the patients cannot have MRI because they have a pacemaker, for instance. So that's a contraindication for MRI for breast. So they had the imaging done before with an ultrasound, for instance, or with a mammogram. So they get followed with those.
Okay. And then you're, of course, continuing to follow after the treatment annually,
annually.
Or as needed.
Right, that's correct.
Dr. Paredes, you're up. Can you talk a little bit about reconstructive surgery following a mastectomy and your role in that process? And just in general, are all patients who have to undergo or choose to undergo a mastectomy candidates for reconstruction?
Thanks. I'll start with that last question. Everyone's a candidate for a consultation. So anyone with breast cancer can come to us and talk about options they have. Sometimes I'll meet patients who still haven't decided between lumpectomy or reconstruction with mastectomy. And so we sometimes help patients along the way with, maybe you would be better off with a simpler surgery like lumpectomy, or maybe you want a full mastectomy, and then we come into the picture to discuss reconstruction. We can actually help both cases. Sometimes we can help reconstruct a breast that gets just a lumpectomy, just a small piece of the breast removed, but maybe we need to move some tissue around, lift it, rearrange it to make it look appropriate, and then let radiation happen afterwards. Sometimes a patient chooses mastectomy, and some may want a reconstruction, some may not. Sometimes the consultation helps a patient decide if they want reconstruction or not. So I think it's a good idea to get the consult just to know the information one way or the other. And then reconstruction comes in for a mastectomy in different flavors. Sometimes it's done with the mastectomy. We call that immediate reconstruction. And it's really just starting the process immediately. You don't typically wake up with a fully reconstructed breast. It is a staged process. I tell patients we will become good friends over a year because we'll see each other a lot over a year time. They'll see us more than they've seen their primary care doctor in 10 years sometimes. And then the stages depend on what we're doing. So, if we're going to do it, whether it's an immediate or delayed reconstruction, delayed would just mean we would let you get through your cancer care first and then come back later once we feel that we've adequately treated the cancer. And then we come back once we know the cancer has been treated. So that's just called delaying the reconstruction. But the reconstruction can come generally in two formats, whether it would be an implant-based reconstruction, meaning we literally take something out of a box, it's called an implant, and place it inside to create a mound. Or we use a patient's own body tissue to then create a mound. That can be taken from the lower abdomen, it can be taken from the back. There's actually some even more, we call them boutique flaps, that can be taken from the hips, the buttocks. There's actually different places we can take tissue. But all of these are ways of reconstructing a mound. And then following that, we can actually reconstruct a nipple. It looks like one, it doesn't function like one, but it does have the appearance of one. And then after that, we can finally finish up with a tattoo that makes it look like a realistic areola. The good news is that since 1998, Congress passed a federal law that required reconstruction to be covered after a mastectomy. So all insurance companies must follow federal guidelines, which means it is a covered procedure. And it does include not only the cancer breast, but it also includes the other breast if a woman decides whether she needs a mastectomy on that side, or even if she just needs what's called a symmetry procedure. All of that is covered as well. So that gives a lot of people peace of mind knowing that they really can't choose what they want to do and their insurance will cover that for them. That process takes us about a year for some people. For some people, it's only 4 or 5 months. But in that consultation process, we're looking at sort of candidacy for how healthy you are to have surgery, and are you really a good candidate to have multiple procedures. I would say that most people generally are, but that's the purpose of the consult, is to assess your health and whether you can be put to sleep with anesthesia and things like that. And then we're looking at the stage of the cancer. Usually earlier to, let's say, middle stage cancers are going to be candidates for immediate reconstruction. Later diagnoses, meaning it's a later stage cancer, worse prognosis, we're probably going to wait to get the cancer care done first. So there's no chance we might delay that care and then come back later with a reconstruction once they get through all that process.
So do you have patients that sometimes will wait, they'll have a mastectomy and then come back a year or 2 years later for reconstruction? Is that possible?
Yes, definitely. And in fact, I will have patients who, by the time they've reached me, they have literally hit everyone else on the screen. And so when they get to me, they're overwhelmed. And sometimes when you're talking about a mastectomy and just the idea of going through that and the chemotherapy that might come afterwards, what I find is that you get patients who are just, they're mentally taxed. They're overwhelmed with the amount of information they're getting. And when we start getting into reconstruction, and it might take a couple stages or 3 stages, for some people, it's literally too much. Like they don't want to think that far into it. They just really want to treat the cancer first. And when I get a patient like that, I'll recommend, listen, let's just get through the cancer. We just had a talk. That's all we did. Go through your cancer and come back to me later. So I'll have patients come back to me 6 months or 6 years later. The good news is there is no real time clock on coming back to do a delayed reconstruction other than really your age and health. You don't want to be 50 years old with your diagnosis, come back when you're 100. Maybe we waited a little bit too long, but you can wait 1 year, 2 years, 3 years. In fact, I have patients who tell me I don't want reconstruction at all. And 2 years go by and they sort of see what it's like to live without a breast mound. And they change their mind and say, you know what, I've changed my mind. I want to come back and create a mound. How can we do that? So that's called delayed reconstruction. We do that all the time. So I try to help patients understand there really is no pressure to get reconstruction. Sometimes I do think particularly women will feel pressure from a niece or a daughter or an aunt or a neighbor. and that, oh, you got to reconstruct it. You can't just walk around like that. Really, that's not the case. You really need to make this decision for yourself and decide mentally and physically how much you want to go through in the midst of a cancer diagnosis. And if you feel like you just need to come back later when the dust has settled, so to speak, that is perfectly fine. It's actually safer to do it later if you really want to know.
Interesting.
Yeah, because it's less being done at one time.
That's really interesting. Well, this is a great segue into a question someone asked on Zoom, which is, do doctors realize how overwhelming the information is when a patient first comes to the center? And, obviously the answer is yes, you just addressed that. I want to go to Dr. Silberman, who's also a psychiatrist, to talk about the role that mental health actually plays during a breast cancer diagnosis and the resources that we have available to address this issue, just the overwhelming nature of a diagnosis like this.
Thank you. It's such an important topic. Our goal is to treat the entire patient, and that means their mental well-being as well. As you can imagine, because breast cancer is so common, so 1 in 8 over a lifetime, we're seeing basically a cross-section of our community. So a lot of people are coming in with pre-existing mental health conditions. Many of them are under stress, or everybody's under some sort of stress from their diagnosis. Some might be experiencing something more mild, like an adjustment disorder with a little anxiety, or some mood dysregulation that's shorter term and easily addressed. And some people might have more severe mood disorders or anxiety disorders. I also have a fair number of patients who have chronic psychotic illnesses, that were pre-existing. So, my goal is really to try to minimize the stress on the patient by addressing as many of these things as I can when they come in to see me. So for my patients, and I think many of my colleagues as well, we're doing medical management for their anxiety and depression and sometimes psychotic illnesses. Unfortunately, we don't have enough time that we can also do therapy with them. However, it is offered at the Cancer Center. We have some very well qualified licensed clinical social workers who provide psychotherapy for our patients. We also have navigators. I think somebody touched on that earlier, who are either social workers or registered nurses who are able to help the patients navigate through this. I think the one thing that you're probably noticing at this point is very multidisciplinary, very complicated sort of system. So just to sort of ease their mind, if you have questions about the logistics of what's happening to you, or where am I in my treatment, or are my various providers communicating with one another, they can go to the navigators who will hopefully relieve a fair amount of that stress. We also have support groups, which they can be referred to. So there are a number of things that we can do, and absolutely my goal is to treat the entire patient.
And when you first come to the Walker Breast Center, are you assigned a nurse navigator or someone to help you go through all these multidisciplinary areas?
You are. So Amy Anderson, who unfortunately couldn't be here tonight, I know she usually is here, is our head breast cancer nurse navigator. We have a number of other wonderful navigators who step in and help out and make contact with patients and help with that communication.
I'm going to stick with the mental health, Dr. Silberman, for just a minute. One of the participants in the panel mentioned that they have a second imaging appointment tomorrow with CHP, and they're asking how they can best prepare to be informed despite the anxiety that goes along with a follow-up appointment like that.
Right. Do they already have a breast cancer diagnosis, or they're just being called back for
It looks
diagnostic
like a
imaging?
second imaging appointment tomorrow for their left breast, and that's all
Okay,
they're
so some
sharing. Yeah.
abnormality.
Yeah.
That
Yeah.
is a very common, fortunately, most people who are called back, and Dr. Lockwood, please correct me if you disagree, but my understanding is that the majority of people who are called back for diagnostic or further imaging do not have a breast cancer diagnosis, that there are many, many women who fall in that category and may have to come back with more frequent visits every 6 months, or may need MRIs or ultrasounds in addition to annual mammography. So it doesn't mean just because you're called back for diagnostic imaging does not mean that you have a breast cancer diagnosis. So I think that would be the first thing that I would tell the patient to reassure them.
if I may, when we call a patient back, remember the breast every year, we're going to do the exam, and every year is not going to be the exact same exam, because your breast, you might have lost weight or gained weight, or the position is a little bit different. Sometimes the tissue overlaps. If you have dense breast, it's more difficult. So we are just looking at Waldo. We're looking for Waldo, if you remember that cartoon. So whatever changes, we want, like I said, we want to find the things where they are small. So we call you back. So I would think of 100 patients, we call back 10%. So 10 patients come back. And of those, the majority are not going to have anything. So where is so don't I always kind of try to make a point. If we call you back, don't cross that bridge until you cross it, right? Don't get stressed, because before crossing the bridge, that might be just nothing. It's just breast overlapping, and we want just to make a spot compression, something more focal to the area that we're seeing, to separate it, to make sure that there is nothing. Sometimes you have cysts, which are benign, and once we see it that it's a cyst, we tell you it's a cyst, which is a fluid containing structure, nothing to do about it, you can keep it. So it's so many things like that happens when you come back, that we see and they are benign. And then I probably, so that part, try not to really fill your head with all the unknown things that could happen, because be assured most of them are going to be negative. And then when there is something, then of those somethings, not all are going to be cancer either. We're going to biopsy many things that are going to be benign, and they are just the looks of it can be a little bit concerning. So that's why we need to do the needle biopsy. And thank God for all this technology that we can do things with needle, that we can get the diagnosis right away, that you don't have to be under anesthesia or anything like that.
Thank you. Is there a breast cancer support group through TMH and through the Walker Breast Center? Do you know, Dr. Blank? I would assume you would know that. Somebody's asking.
There's a general cancer support group, and I don't want to give the right time, but on their website it gives their monthly meeting. So there's two. That's one. There's actually three. So there's one. There's another that's kind of a high risk support group. It's called Force. It sort of was pretty strong before COVID. Things got a little interrupted, and now it's kind of picking up again. So it's been headed up by our clinical geneticists. So we realized that there wasn't a place for people who had high risk by family genetics or carried a gene but didn't actually have a breast cancer diagnosis. And so they were kind of in between cancer and benign world. And then there is a great, very active local support group called the Joanna Francis Living Well organization. And they meet monthly at Goodwood. And they're very, closely aligned with TMH as well. But so between those three, there's really kind of a lot of opportunity for local support.
And those are available on the tmh.org/breast cancer website. So
Yes.
Anyone can go to tmh.org breast cancer. Dr. Paredes, I'm scared to ask this question. Can you talk, and I'm not a smoker, but I know that nicotine presents challenges, not only as a risk factor for breast cancer, but during recovery. But I also know that there is some evidence that you have to be sensitive to your use of alcohol. And I will tell you, I like having a glass of wine. So I want you to tell me about nicotine and wine and alcohol in general, and just the impact that those can have on recovery.
Let's start with nicotine first. So first thing to understand is nicotine is a very powerful carcinogen. It is a significant impact on the cause of cancer throughout the world. So I will tell patients, here we are to treat your breast cancer. It really doesn't make sense to keep using a carcinogen as powerful as nicotine and cause other cancers. And I've seen that happen in my patients. So we do, number one, try to get them off of nicotine just for the cancer causing risk that it presents. That's not so easy, of course, because it's typically an addiction. There are different ways we can help patients stop using nicotine. And it's important to understand it's not just smoking. That includes vaping nicotine. Putting a patch on your arm is still delivering nicotine. Chewing Nicorette gum is still getting nicotine. If you're using it to quit, I applaud that. But if you're going to use it for 6 months or more, you're just getting nicotine in through your skin or through your mouth. So it's really any nicotine ingestion is the problem. We often get asked smoking different things, THC, marijuana, cannabinoids. Those actually don't have an impact on the surgery that I'm going to do like nicotine does. So it really is nicotine is the issue. Nicotine itself, besides causing cancer, raises the risk of infection 4 to 8 times. It actually poisons your white blood cells. They can't make it to the site of an infection and actually fight the infection. So when you have nicotine on board, when you get an operation or surgery, you have a higher risk of infection. That can affect your mastectomy, it can affect your lumpectomy. If you're going to be getting radiation 6 weeks later, now all of a sudden we have to delay the radiation or delay the chemotherapy because you have an infection. So it can have very negative consequences in the treatment of your cancer just from the standpoint of delaying your care. But it also makes you not heal as well. So between infection risk, your skin can not heal appropriately. It can even make your skin die during a mastectomy. So it has some really negative effects. So we try to get to patients as early as possible when they get that call back and they get that first diagnosis of breast cancer from Dr. Lockwood in the radiology department. It's really good, and I know radiology has been doing this, to try to tell people you really want to stop smoking immediately, because every week that goes by between your diagnosis and the cessation of nicotine will have a positive effect on how you heal the upcoming surgery that you're having. So there is this window of opportunity for patients to stop using nicotine the moment they're diagnosed. We help patients in that regard. Sometimes we'll prescribe Chantix or different medicines that are out there that do assist with nicotine cessation. Sometimes we'll delay a patient's reconstruction if they are an active nicotine user at the time of the mastectomy, so that we can actually get them nicotine free for somewhere between 60 and 90 days is what most people need to clear the nicotine metabolites out of their bloodstream. So the nice thing about reconstruction is we can just say, let's slow down your nicotine use, go ahead and have your mastectomy, come back a few months from now when you're nicotine free, and we can more safely proceed with your reconstruction. That's the ideal world. Sometimes you have to kind of bite the bullet and move forward despite having nicotine on board, because we don't want to delay that mastectomy forever, because we don't want the cancer to spread. So we'll work around nicotine the best way we can. When it comes to alcohol, there's less impact for me as a surgeon with alcohol use. A lot of alcohol use can thin your blood some. So you actually have a greater tendency to bleed, especially if you have liver disease. So now we're talking a little bit more about the amount of consumption you're talking about. 1 glass of wine is not going to affect my surgery. I'd probably let Dr. Silverman chime in on how much she thinks 2 or 3 glasses of wine per day affects cancer risk. But 1 glass of wine is really not going to affect us too much, other than, you're going to be getting certain medications that might be negatively impacted by alcohol consumption because it is a diuretic. And so generally speaking, I'm going to advise patients to slow down their alcohol consumption as we're getting closer to surgery, and definitely beyond surgery, and definitely not resume nicotine use after surgery, especially because we're trying to cure cancer, and it doesn't make sense to use a cancer-causing agent like nicotine after surgery.
Dr. Silverman, you want to address the alcohol issue, alcohol and cancer?
The consensus is to limit the amount of alcohol to 6 ounces. In other words, if you're going to drink wine, 6 ounces of wine per day or less or none. And that seems to be a safe level in addition to all the other lifestyle changes. So for example, we now know that there's a correlation between regular physical exercise, in particular intensive exercise, where you get your heart rate up and break a sweat, and a reduction in your risk of breast cancer recurrence. So for many years, we've been counseling patients to increase their exercise. And there are many reasons to do that. To increase your bone mineral density. Patients have less anxiety and depression. They have lower blood pressure, lower hemoglobin A1C if they're diabetic or pre-diabetic. But now we do know that it lowers your risk of breast cancer recurrence, in addition to other cancers that are associated with obesity.
Thank you for letting me have that one glass of wine. I appreciate that. That's good news.
We're not,
No, it's
we're
something.
not barbarians.
Yeah, I appreciate that. This is a great team. I told everybody that when we started. I really want to get to survivorship and beyond because it's 6:55. And also just remind everybody, the Q&A is still open for questions. There have been some terrific questions from the audience. But Dr. Popple, tell us what survivorship looks like from a medical perspective. So at what point after you go through this process and we've, met with everybody and we've had surgery or not, we've had radiation, we've had chemo, whatever we've gone through, what point do you consider someone from breast cancer in remission or cancer free?
It's a good question, and it's one we get asked. Personally, I think survivorship starts really from the minute you're diagnosed, and patients can be, survivors of breast cancer at various stages along their journey with and without evidence of disease. They've survived the hardship of a diagnosis and all that entails. But, in patients without evidence of disease who we're surveilling, imaging and regular physical exam is a standard and important part of the surveillance program. We here, recommend that patients with intact breasts undergo diagnostic mammography every 6 months from the completion of their breast conserving therapy for the first 2 years, and then certainly annually thereafter. And you see most recurrences happening in the first 5 years. And so it's not that you can't develop a late recurrence. Certainly, we all know breast cancer can do that, unfortunately. But the risk, per year kind of drops off after 5 years to a lower but not zero risk. And so unsatisfyingly, I'm not sure there's ever a time point in which we feel comfortable telling a patient this is for sure never, able to come back. But certainly we ease off some of the surveillance measures after that time point.
You continue to recommend, just as you would for the general population, 40 plus, a mammogram every year at some point, even if you've made it beyond the 5 years.
Right, absolutely. And for those without intact breast tissue, like, for example, patients who have undergone mastectomy, it's still very important to undergo routine physical exams by a provider, but also to keep in touch with your physical changes yourself and examine yourself as well.
Thank you. And I want to ask Dr. Everidge, so much is happening on the breast cancer front. I mean, it's remarkable how quickly things are changing. And, 30 years ago, 40 years, this is a scary diagnosis, no doubt, but there was, it was much scarier at that time. There was so much less known, so much more known. Can you talk about the general prognosis, Dr. Everidge, of the disease now compared to the past and why we're in such a better position to treat breast cancer?
Yeah, I'll start off by answering the last part of that question. The answer is screening mammography. Because we're screening breast cancer patients, we're catching breast cancer at such an early stage. And because of that, we're able to treat these patients. And the majority of patients that are getting diagnosed at these early stages have a upward of 90-something% 5-year disease-free disease recurrent survival. So a lot of people are living after their breast cancer diagnosis for a long time, and that's because we're able to catch it so early.
That's really encouraging. I'm going to keep you on the spot, Dr. Everidge. 2 great questions just came in. And with an understanding, there's so much information that goes into this. There's no way you can definitively answer these questions. But someone has asked we talked about the length of possible radiation treatment, which varies. What about chemotherapy? Is it the same? It varies patient to patient, cancer to cancer? Or is there a typical?
Yeah, I would definitely defer that question to Dr. Silverman.
Okay.
But as with everything in breast cancer care, a lot of it is individualized.
Okay. And then following up on that, for metastatic breast cancer patients, is surgery always recommended, especially if the cancer is in the lymph nodes? Or again, to the team, that's a very individualized response or answer?
Yeah, so metastatic to the lymph node doesn't necessarily entail stage 4 disease. For stage 4 disease, usually surgery to remove the breast cancer is foregone at that point because we're kind of at a management stage as opposed to a curative stage. For breast cancer that has metastasized to the lymph node, so that's local regional disease, there is still a role for surgery.
Okay.
Usually there's therapy on the front end in the sense of chemotherapy, but yes.
Dr. Silverman, do you want to add anything to that on the
Well, to your
chemotherapy?
question about the duration of chemotherapy, it depends on a lot of different things, but just to sort of summarize the highlights, I would say that patients who are being treated for cure, who have lower risk breast cancer, might receive chemotherapy for about 12 weeks or 3 months. Patients who are higher risk, node positive, have triple negative disease, would be receiving chemotherapy for 6 months. In the case of HER2 positive disease or some triple negative patients who were identified early on before surgery, they might be receiving longer course of treatment. So Herceptin for HER2 positive breast cancers, mutated breast cancers, typically receive treatment for a full 12 months. However, not all of that includes conventional chemotherapy. So during most of the part when they're receiving the targeted agents, which might include Herceptin or Perjeta, they tend to feel much better than during the more intensive conventional chemotherapy portion.
And
Does
someone
that
just asked
answer
a
your
really good,
question?
yeah, I think that's great. And someone just asked to follow up on that. Can you talk about, for those who may not be familiar with it, what the difference is in radiation and chemotherapy?
So that's an excellent question. And I save that typically for the end of this. I love this forum, and I think it's an important point because this comes up so much. Patients often become confused, and understandably so, that wondering if I omit radiation or if I have mastectomy instead of lumpectomy, does that mean that I can forego endocrine therapy or chemotherapy? And the answer is typically no. And the reason for that is all these treatments are it's an interdisciplinary sort of cancer, so they're all complementary, and so our high cure rates are reflective of the fact that all these treatments work together. They're typically given sequentially, and the reason for that is to minimize side effects, but it isn't as if you can forego one and still end up at the same place in terms of cure rates. Is
One
that
thing we
part
did, no, that's
clear?
perfect. And one
Okay.
thing we didn't address just very briefly is something I deal with, which is an aromatase inhibitor for people who have an estrogen-fed tumor. Can you talk about what that is, that type of treatment?
Sure. So it's an anti-estrogen, and we typically reserve that for after menopause has occurred because it doesn't work via the ovaries, which is the primary source of estrogen prior to menopause, which in this country is typically around age 52. So we use this for anywhere between 5 and 10 years for patients that we're treating curatively. For patients with metastatic disease, they might be on this medication for much longer than that. In terms of side effects, most commonly they're vasomotor side effects, so hot flashes. Some patients may not have had hot flashes at all when they went through menopause, and then we put them on the aromatase inhibitor, which prevents the conversion of other sex hormones like testosterone to estrogen in the fat tissue of the body. So that's the first thing, hot flashes. Sometimes people will have stiffness in the joints that tends to be worse early in the day and improves with use. So I'm always encouraging folks to stretch and exercise. Sometimes it's prohibitive. So if one of those side effects is too severe and it really impairing their quality of life, I might try to switch them initially into a different medication within that same class. So we have a number of different aromatase inhibitors. I might try a different one. Now, why would I try a different medication within the same class? Well, after menopause, the aromatase inhibitors work better to prevent breast cancer recurrences. Now, we also have tamoxifen, which works via a different mechanism as a serum estrogen receptor modulator we can use in premenopausal women. And that has a different set of potential side effects. The one other thing that I would mention, which is really important, is after menopause, there's a decrease in bone mineral density just normally. And when we throw in the aromatase inhibitor, you can accelerate that bone loss. So I'm very aggressive about treating that. I get a baseline DEXA scan on all my patients who are on aromatase inhibitors, and then every 2 years. And if they do have any osteopenia or osteoporosis, I'm going to recommend calcium, vitamin D, weight-bearing exercise. And if it's severe enough, so osteopenia that's affecting multiple locations or osteoporosis, I am probably also going to recommend either Prolia or an oral bisphosphonate. You might have heard of some of them. I think Sally Field was doing commercials for Boniva at one point on TV. So one of those medications to help prevent the development of fractures with mild trauma.
They're just remarkable tools in the toolkit that we didn't have for many, many years. And now
Yes.
research has shown that you can literally target, and I'm the beneficiary of a second round of hot flashes, thanks to you guys. So
Sorry, I'm
but
sorry.
it's a
But
small price to pay.
it is, and I would just add also that those medications, endocrine therapy in particular, aromatase inhibitors, decrease the risk of breast cancer recurrence by 50%, 50. So
That's
they're very
amazing.
effective.
That is amazing.
Those
Somebody just
medica-
gave you
those
the
med-
thumbs up.
It was our only thumbs up. Those medications can also be used as risk reduction medications too. So in people who
Yes.
have particular high risk biopsy results or high risk family history or a combination, they are also very effective as what we call chemo prevention or a risk reduction strategy in people who haven't actually been diagnosed with breast cancer but high risk for various reasons. So.
Amazing. It really is. Well, we are at 7:06. I have let us run 6 minutes over, but this has been a fascinating conversation. I want to close by just saying, we're coming to the end. I want to do a quick round robin. What's one thing that each of you want breast cancer patients or family members, or just people who are, trying to learn more about breast cancer to take away from this discussion? Let's start with Dr. Average, because I see you first on my screen.
Don't forget your screening mammogram. And I think that regardless of what everyone says, I think we're all thinking that that's really the point of October being Breast Cancer Awareness Month. We're aware of breast cancer all the time, but this is our month to scream and shout from the top of our lungs. Don't forget your mammogram.
Thank you. Dr. Silberman?
Well, I think that is a wonderful thing to highlight. Just to be different, I'm going to say, please don't ignore any of the signs or symptoms. A lump in the breast, a lump under the arm, come get attention. We do this all day, every day. Have confidence. We will approach it empathetically, and we'll take good care of you. So, I see patients all the time. I saw somebody today with a mass in her breast for 3 years. And so now the situation is much worse, obviously, than it might have been earlier on. So I'm kind of piggybacking on what Dr. Everidge said, but if you've gotten beyond that point, and there are many people who've never had a mammogram or haven't had one for 15 years, if you do develop a sign or symptom of breast cancer, please bring it to somebody's attention sooner rather than later.
Perfect. Dr. Popple, what would you add to that?
I would add that we all, as people who deal with breast cancer patients every day, recognize, without having, gone through it ourselves, how overwhelming this can be. And we want you to, come and share your burden with us. We all care very much about this community, and we want to help you get through what can be a very overwhelming experience. And we have a plan for you. And we all work very closely and have, cutting edge technology available to us to best care for you. So don't let the anxiety of the diagnosis, prevent you from seeking our help, because we've got a good plan.
Perfect. Dr. Popple, thank you. Dr. Lockwood.
Definitely, I echo everything that they said. But very important, 40 years old, you hit that age, you need to have your screening mammogram every year. Don't forget, is better early than late. And so the way not to forget, you just do your appointments in your birthday or 10 days after your birthday. So it's a date that you will remember. And that way you don't skip. So don't skip.
That's a good way to calendar. That's a good way to think about it. Dr. Paredes.
In a similar vein, I would say to those out there who are just recently diagnosed or who've been diagnosed in the past, you can do this. I know it's very scary. There's so much awareness about breast cancer. You just don't want to hear those words. But I tell patients in our consults all the time, you can do this, and you have a team of people. You're looking at several right now who will help you get through this. We have dedicated thousands and thousands and thousands of hours of learning about this and trying to do the best therapies we can find to cure your cancer or to make it so you can live as long as you can with your cancer. So you've got a team of people in Tallahassee who are truly dedicated to helping you get past the finish line.
Is amazing. This team has your back. And I doubt there are many communities in America where you could get the top breast surgeons, oncologists, radiologists, psychiatrists, fellowship trained breast surgeons who would spend this amount of time during the month of October with the community, just saying, we got your back. And TMH and the Walker Breast Center have that. And so I'm going to kick it to the director of the Breast Center, Dr. Blank, to close us out now with her thoughts and to provide any resources that I have forgotten to ask about.
No, thank you, Sally, for your time and your investment. We really appreciate it. And I couldn't say it better. You do have a team. We are all obviously super passionate about this. And it's because of our patients. And I think we develop such close relationships with our patients. Breast cancer is not a death sentence, but and there's great treatment, but you have to get to that treatment, and you have a team that's going to be there for you and kind of get you through this process. So I think you've outlined, those resources here. But if there's anything that you have questions about, there's good information on our website. And you can, see any of us if you have just a question about maybe you have high risk or, something that you're concerned about, don't ignore it because treatment's just around the corners.
Thank you all so much. This has been amazing. Fantastic information. Thank you for what you do in our community. We are truly grateful. And just for the participants that have zoomed in, tmh.org/breast cancer. Get your mammogram, get it scheduled if you haven't had it. Everybody have a fabulous October. And thanks to this entire team. Y'all are amazing. We're really, really grateful.
Thank you, Sally.
Thank you.
Bye.
Thank you. Bye.